Perfect. Thank you so much. So, welcome everybody. I am Ted Carbone. I've worked in collaborative care for several years. Was the director of strategy at Concert Health for about 2 years, and kind of got elbow deep in all things billing and finance. Worked with our value-based care team, and now I work as a consultant, providing support to practices across the country that are implementing collaborative care, and everywhere, kind of running the gamut from clinical all the way to data and billing and finance as well. So hopefully can bring a nice, well-rounded view to this topic. I know billing and finance is not everyone's favorite thing to talk about and can sometimes feel a bit dry. So we'll do our best to keep it as lighthearted as possible and engaging. So please feel free to use the chat as much as possible, ask lots of questions. We will have lots of FAQs at the end, just frequently asked questions that I've received in the past, and that the AIM Center has provided some guidance on as well. So I may just say we'll get to that, but please go ahead and drop those in the chat, and we can keep it pretty informal. All right, so with that, I'm going to go ahead and get started. I'd love to know what state everyone is in. So if you could just, I don't know if everyone here is Texas. I know we've got a good majority, but I saw one South Carolina. So if you could just throw in your state in the chat, that would be, oh, perfect. Okay, awesome. Yeah, that'd be, oh, so all over. Great. So that would be super helpful. So when it comes, well, when we get to the part about Medicaid, you'll hear me talk a lot about state specific. So just kind of keeping that in mind, but it's helpful for me to know kind of geographically where everyone's at. All right, perfect. So we're going to go ahead and get started then. And we're going to today discuss the collaborative care CPT codes and the services covered under each one. We'll also talk about the general BHI codes. We'll discuss some billing limitations in FQHCs and RHCs. Discuss the role of the PCP in the billing process and some other things that sort of came to me as I was putting this together that maybe didn't fall into any of these categories. So I will preface with bear with me, and if it's feels a little out of order, I get excited about things and sometimes put it in multiple times on the slideshow. So if you see me run through a slide really quick, it's probably because I remember that I have it in there again later. So, all right, we'll go ahead and jump right in. So just to kind of set the stage here, we are talking about collaborative care, and so specifically in collaborative care, the behavioral health care manager qualifications. I hear a lot of questions about that. And we'll talk again later about this because I bring it up again in the FAQs. But from a billing perspective, the only thing that the billing guidance tells us is that the BHC must have formal education or specialized training in the area of behavioral health. So this could be psychology, this could be social work, this could even be nursing. And one important thing to call out is that because they're not, this is not psychotherapy, this is a primary care billing code, there's no need for licensure. So just know the qualifications may vary, and I will say the billing guidance is intentionally vague on what formal training or specialized training means. We'll talk a little bit kind of about the why behind that later, but we'll go ahead and move forward here. But any questions on this? Like I said, any questions, just throw them in the chat, and I'll pause and we'll just chat through it. Try to keep it, like I said, as informal as possible in this setting, just for the sake of having an open dialogue. Okay, so payment for general BHI services. So CMS provides a separate payment for the general BHI services. These are also billed under the treating medical provider. So the CMS rules means that clinical staff can provide these services in addition to the BHCM. And the BHCM or psychiatric consultant are not required. This is for the BHI code, the 99484. So this is separate from collaborative care. And again, like I said, these are a little bit out of order, so we'll dig a little deeper into this when we get into the specific codes and what each code means. But just wanted to put that general disclaimer out there. So Texas in particular, but really all states kind of follow these core principles, these 5 core principles that define collaborative care and must inform every aspect of our implementation. So that's patient-centered team care, population-based care, measurement-based treatment, evidence-based care, and accountable care. And so really kind of thinking about these core principles, that any of the work that we're doing that's falling under those core principles generally will be considered billable time. And again, we'll talk more specifically about that as we move forward. Okay, so general billing guidance. And this is kind of where we're going to get into the nitty-gritty of the billing, right? So one thing important to call out, codes are used to bill for monthly services, right? So this is very, very different from what we're used to with psychotherapy or primary care or specialty care or outpatient behavioral health, right? That they're billed per visit or per encounter. Collaborative care is a monthly case rate. So what that means is we're not billing until the end of the month, and we're tallying all the time that has occurred throughout the entire month and figuring out at the end of the month which code fits based on the total amount of time and the care that was provided. And then we bill that code at the end of the month. So that tends to be a sticky point for some practices that are implementing collaborative care for the first time, just because it's so different from what we're used to. So just an important call out that it's not per phone call, it's not per visit, it's not per encounter. It is a monthly billing case rate. Okay. This is a primary care service, so it's billed under the primary care provider. Typically, there are some nuances there where we might be billing under a different medical provider. For example, maternal health, if we are providing care for a pregnant or recently postpartum woman, and they're receiving their primary medical care from their OBGYN, that OBGYN can bill collaborative care. So, there are some caveats there, but typically it's billed under the primary care provider or whoever is providing the primary care for that patient. And again, important call out that these are medical codes. Even though it's psychiatric collaborative care management, this is not falling under the patient's behavioral health benefit, and they're not billed by the clinical social worker or the counselor or the psychologist or the psychiatric provider, the psychiatric consultant. They are billed the medical provider as the billing provider. We'll talk more about that again as we kind of move forward, but something just to keep in mind. And with that, just like I'll put a little plug in for documentation, just keeping in mind that these notes are medical, they're part of the medical record, right? So we, I don't want to go down a rabbit hole there with that, but just something to keep in mind that we're not writing SOAP notes or, traditional psychotherapy notes. These are encounter notes, and they are part of the primary care record. Medicare considers all the service provided by the care team as incident to the billing provider. So this basically means the billing provider or the primary care provider is involved in the care. Cost sharing may apply, and I'll talk more specifically about that later on as we talk about different health plans. And eligible conditions include any behavioral health condition that is, quote, in the judgment of the billing practitioner and warrants services. So I will put a caveat in there that some states, I see someone in here from New York. Some states, such as New York, their Medicaid does have a list of approved diagnoses. Pretty extensive list, but it's something to keep in mind that some states for Medicaid, they do have some additional specifications there. So I would consult your state's guidelines if you're billing Medicaid in your state. But generally, any behavioral health condition, any of the DSM-5 diagnoses, any of the ICD-10 codes related to a behavioral health condition would be eligible. So the patient does need to have a behavioral health condition diagnosed by the primary care provider in order to refer to collaborative care. Now, that being said, that primary care provider could choose a like an unspecified diagnosis, right? Anxiety unspecified, depression unspecified, a provisional diagnosis. And then the clinician, if we have a behavioral health care manager who is a clinician, or if they're in consultation with the psychiatric consultant, then they can diagnose that patient more specifically. So we don't need a specific diagnosis, but we do need some sort of behavioral health diagnosis from the primary care provider in order to initiate the collaborative care services. Okay, so I talked already about a monthly case rate. I'm going to talk about it again, and I'll probably talk about it again before we're done, because it's so important. Because that is typically where I see denials come in, is multiple codes billed different points in a month, because a practice is thinking about this in more of a per visit capacity rather than a monthly capacity. So keeping in mind, again, monthly case rate. So, and again, what's included, what's not included, I'm going to talk about that again later in the FAQ section. But collaborative care tends to be mostly telephonic. That will vary from practice to practice. I have seen some practices where all of the care is provided face to face. I will say I think it's somewhat side of the fidelity of collaborative care to a certain extent because it's meant to be care management, it's meant to be frequent, it's meant to be sometimes brief encounters. And so telephonic care really lends itself very well to that. That being said, there can be an in-person or video to supplement. And in fact, one of the billing requirements is that the behavioral health care manager is available for an in-person visit if requested by the patient. And we'll talk more about that later. Um, Even though the majority of the care is telephonic and or sometimes video based, this really important to note, these are not telehealth codes. We do not use a telehealth modifier. The place of service is still the primary care office. That's because the primary care provider is overseeing all the care. They are the biller. And just like sometimes the primary care provider's nurse might call a patient to, check on their blood pressure for the week, right? If we're asking them to keep a diary of their blood pressure on a primary care level, that's not a telehealth visit, right? So just keeping that in mind, we're not using telehealth modifiers here. It's already kind of bundled into the code. And then I just did put like a little caveat here: an increasing number of private payers and state Medicaid programs are recognizing and reimbursing for these codes. So check with your local payers and your Medicaid to determine if reimbursement is offered. I'll talk more specifically about that as we move on, but just something to keep in mind. Okay. So general billing guidance. I'm going to talk again about the CPT time rule. This is kind of a funky one. All right. So the 99492 code, that is only to be billed in month 1 of care. Or let me rephrase. It's only to be billed in the first month in which the patient meets that criteria, and then never again. So what that means is, and why I said not necessarily the first month in care, if a patient comes in care at the, last week of the month, they might not meet the time requirement for the 99492, so they wouldn't get a 99492 that month. And yes, I will share out the slides at the end. So the CPT time rule is 50% plus 1. So basically what that means is, and this is specifically for Medicare and commercial. So the first month of collaborative care, it says 70 minutes in the guidance. What it really means is that you have to have done at least 50% plus 1. So 50% of 70 is 35, plus 1 is 36. So your minimum time to bill a 99492 is 36 minutes. The 99493 is every month after that first month that they met the requirement for the 99492. If they meet the minutes requirement for the following month, then they get a 99493. And that one is 60 minutes is what the guidance tells us. So we know that that really means the minimum is 31. Then the 99494 is our add-on code for 30, each additional 30 minutes. And that is 30 minutes per code. We'll talk about caps on the 99494s and things like that as we go on. But any questions here generally about these 3 codes? I'm going to talk more about them for sure. And I don't, just because of my screens, I don't have everyone's camera screen pictures here. So just chat is best, or the actual raise hand feature. You can use that as well. Can RN time be counted? So that depends. Is the RN acting as the behavioral health care manager? Because again, an RN could be specially trained in motivational interviewing, behavioral activation, and be hired as the behavioral health care manager. If that RN is the behavioral health care manager, then yes, their time can be counted because they are the BHCM. However, if we're just talking about the RN's time and the BHCM is not involved in that time, then no. And we'll talk about that. Essentially, only the behavioral health care manager's time is counted. So if the behavioral health care manager is consulting with the site consultant, or if they're communicating with the PCP, that behavioral health care manager's time is being spent, and so that's being counted. But if the RN is calling the patient about our med refill, as an example, that time is not counted. Yeah, so if the RN is the BHCM, then yes, then that's absolutely fine because they're the BHCM in that scenario. Okay, half plus one, I already mentioned this, does not apply to FQHCs or RHCs. So if you're in an FQHC or RH, actually, if you are FQHC or RHC, let me know in the chat. But just know half plus one does not apply to FQHC and RHC. Perfect. Okay, so you're in terms of RN being the BHCM, not a problem. But yeah, we'll get to FQHC specifically because they're okay, perfect. They're a little bit more nuanced in terms of the number of minutes. So a whole separate section we'll talk about them when we get there. But to just forget about what I told you about the plus one. It won't apply to you. Okay, so maximizing billing, capturing everything, right? So we're going to talk about what is included. I have met so many practices where they are leaving time on the table because they didn't realize that, the time spent updating the registry on behalf of a patient is counted, or the time spent sending a patient a resource, right? All of that time is countable time. And so we'll talk a little bit about I will say if utilize your registry to track your minutes, um, towards, kind of build in a workflow where towards the end of the month, you're using your registry to realize, wait a minute, there's some folks here who, are outside the threshold of time by just a few minutes. Let me give them a call, right? Let me touch base. And honestly, from a clinical perspective, right, it's best practice. Let's touch base with our patients. So RHC, I'm going to talk about those codes separate because they're different codes, totally different codes. So their minutes requirements are different. So we'll talk about that. So yeah, utilizing your registry, sorting your patients by how many, least number of minutes, making sure that we're providing a good amount of care to everybody across the registry. And that's why we use a registry and we're not just using appointments, right? Our calendar doesn't guide our day, our registry guides our day. And that's always the guidance I give care managers. So looking at your registry, who needs me right now, right? Who have I not contacted this week? Who have I not had a PHQ-9 or GAD-7 on in the last, month? Who needs a site consultation, right? Because that time spent in site consultation on that patient is billable time as well. So just keeping that in mind, it's really good clinical care and it's going to drive the finance side of things. Okay, so I talked about the codes a bit. I'll talk about them again. Again, disclaimer, these do not apply to FQHC or RHC, so I will get to those separately. And I will also say that some Medicaid plans have different codes as well. They usually will use these codes, but they may have a different BHI code. So we'll talk about those. So I think we pretty much covered this already. I will say the 99494, we just want to make sure that when we're billing that, all of our codes are billed at the same time, right? So we're not billing like, oh, they met 60 minutes. Now I'm going to bill a 99493 and it's the 15th of the month. And then, the 20th of the month, they had another 30 minutes. So I'm going to bill a 99494. Like, we're not going to do that. We're going to wait until the last day of the month or the last Sunday of the month, whatever works for your practice, and then bill all the codes for the month at that time. This G code is a Medicare only code. Doesn't, usually apply outside of Medicare. But it's there. And then we have the 99484, which I will get to as well. Okay, so I'm going to get to that. So 99484 is an interesting code. So this is care management services for behavioral health conditions. At least 20 minutes of clinical staff time per calendar month. Now, this one is interesting because it says clinical staff time. So it's not necessarily the behavioral health care manager. It can be clinical staff within the practice. However, this 99484 cannot be billed in a month where the collaborative care codes are being billed. So what typically I see is a practice has collaborative care, they have a behavioral health care manager, and those patients who don't meet the time minimum for the collaborative care, but they do meet the minimum for the BHI code, this 99484, they can bill this code. In theory, this code could also be used in a clinic where there is no behavioral health care manager or psychiatric consultant. And then we have clinical staff doing some care coordination on behalf of a patient for behavioral health conditions. For example, we have a nurse in the practice who is responsible for coordinating this patient, getting their psychotherapy, making sure that their psychopharm, that they're taking their medications as prescribed, and they're doing some check-ins with the patient, um, you know, at some sort of cadence. You can use this 99484 code with that in that scenario. But you can also use it for a collaborative care patient who doesn't meet the time threshold for collaborative care in that month. And it can be fluid. So you can have in month 1, you have a collaborative care code, and in month 2, you have a collaborative care code, but then in month 3, you don't meet the time requirement for collaborative care code, but you do meet it for the BHI. You can use the 99484 in that month. You just can't have the 99484 and then 99492 or 3 in the same month. Any questions on the BHI code, the 99484? So just remember, you can't have this and the collaborative care code in the same calendar month, but you can make it, you can be fluid throughout the course of care. Must bill out all unrun encounter. Yeah. So usually what you'll do is you'll pick the last encounter of the month and you'll just throw all the, or some folks will even just pick, what they'll do is, because with collaborative care, again, like it's not tracked in the same way like other care where it's per encounter. So we don't even necessarily tie it to an encounter. We just put usually everyone in that month will get the same encounter date for the purposes of the CPT code. I've seen practices do the last day of the month, with the 30th or the 31st. But I've seen other practices that they pick the last Sunday of the month, which works if you aren't going to have additional minutes after that, right? The reason why they do that is if you have a really, really high volume practice and you're worried about what if the patient saw the doctor on the 31st and we can't bill 2 codes for the same day. So, you can get a little bit creative with the date. At the end of the day, you just want to make sure all the CPT codes are billed out for that patient on the same day. So you don't want to have one on the 30th, one on the 31st, if that makes sense. Okay, so talking about initiating visit consent and co-payments, and this applies to both collaborative care and BHI. So the 2214 or the 99484, those are the BHI codes, and also those collaborative care codes. So we do have to have an initiating visit for collaborative care. So any patient who, all new patients in collaborative care, and all patients who have not been seen within the year prior to starting the behavioral health services will have to be seen by the treating provider. In that visit, the treating provider will explain the collaborative care process. So when I'm talking about the treating provider, again, we're talking about the PCP most of the time, or the primary care provider. They will explain collaborative care. They will obtain a verbal consent for collaborative care, and they will be informed of any cost sharing. So prior to the commencement of services, we do need to make sure that we've documented, we've explained cost sharing, we've explained collaborative care, and we've gotten consent from the patient. And that is because there is an additional cost to the patient for collaborative care. So we want to make sure that we've gotten their verbal consent and we document that consent. And that we have an initiating visit. So again, that if we're going to initiate collaborative care with a patient, and it can be done via telehealth, that's fine, but we do need to have a visit for that patient. And if a patient is still in collaborative care past the 1-year mark, we want to make sure that they're seeing the primary care physician again. So they need to have been seen within the last year. Yeah, sorry. I say primary care provider, whoever the primary care provider is for that patient can be a nurse practitioner, PA, MDDO, that's fine. Typically, if they're a provider who is billing under an MD, then we'd want to have that MD tied to it. So the patient can see the nurse practitioner, but if that nurse practitioner, if the guidelines through your payer or that nurse practitioner must bill under an MD, then the BHI or the CoCM codes would be billed under that treating provider. So follow whatever guidance you are following for your primary care visits. Whatever that guidance is, it would be the same. But they can absolutely be seen by only the nurse practitioner, by only the PA. That's fine. Whoever provides their care. Okay, this question comes up a lot. Can a patient receive both psychotherapy and collaborative care? And this used to be fuzzy, and now it has been made very clear. So yes, it's long story short, the answer is yes. They can be seen, they can be billing psychotherapy at the same time that BHI codes are being billed or collaborative care codes are being billed. That is not an issue. The only issue is that we cannot double dip the time. So let's say, for example, your BHCM is a licensed clinical social worker or a licensed mental health counselor and is able to bill psychotherapy. But they're also the BHCM for collaborative care. We just have to be very careful that it's distinct and separate so that the minutes that we're billing for psychotherapy session are not also being counted for collaborative care. I don't typically see this. Typically, what I see is collaborative care is provided within the practice, and the patient is also seeing a therapist outside of the practice. And that's not an issue at all. Again, just making sure that the minutes aren't being double dipped, right? Double counting, but it is fine to have both. That was not clear for a while. Thankfully, that has gotten cleared up. I'm gonna skip this one. We've kind of talked about this already. Okay, this is very much out of order, so we're gonna ignore it for now. I think we all know about collaborative care, what it is, what it isn't. Collaborative care is more effective care than usual. We've had 90 randomized controlled trials. We get better depression improvement, lower cost of care. So the thing about the lower cost of care is interesting because a lot of times when we get into that cost sharing conversation with the patient, they get a little, sometimes, depending upon their plan, it may be an issue. So this is where we want to remind them, that they're going to see improvement faster than they would typically with outpatient care. And their cost of care will be lower. The other nice thing is that if they do have a behavioral health like visit max, some plans have, right? Like 12 visits a year, whatever it is. This won't take away from that. So that pool of time is still available to them should they need it or want it later on. Collaborative care is not coming out of that. And typically, because this is a primary care benefit, their share of cost is typically lower. Again, they're also only getting billed once a month, right? So we're only billing one to three codes a month versus a weekly code that we would with psychotherapy. And it's whatever their primary care benefit is. So we'll talk more again about payers and specifically in a second. All right, we're going to skip some of this because we went way out of order. We'll talk about this later, but there's questions about pediatrics and whether or not we can use collaborative care on under 18 population. There is no age requirement in the billing guidance about collaborative care, so it's not explicitly stated as an adult only service. The PHQ-9 and GAD-7 are only validated for ages 12 and up, so most practices will kind of start at age 12 for collaborative care. But we have done some research with providing collaborative care in the ADHD population, which would be 6 and up, and using the Vanderbilt as the treat to target instead of the PHQ, and we've had good success there. So just something to kind of keep in mind from a billing perspective. There's no language restricting the age to bill. Okay. I think we've talked about the codes. Here's this year's reimbursement rates for Medicare. And again, FQHCs, RHCs doesn't apply to you. We'll get to you in a second. But just something to keep in mind. So these are the Medicare reimbursement rates. And I think the majority of us are going to be in this primary care setting column. The other thing I'll say is, commercial plans may reimburse higher than this. So keep that in mind as well. So kind of be dependent upon the contract that your facility has with that plan. Okay, I think we've talked about required activities, but we'll talk about it again. So engagement and assessment using validated measures resulting in a treatment plan. Now, Does not need to be a very long and drawn out formalized treatment plan like you might be thinking of with traditional behavioral health. As the key here in collaborative care is that our goal is a 50% reduction in the PHQ-9 or the GAD-7, or the PCL5 if that's what we're using. But whatever treatment treat to target tool we're using, and that it's a shared care plan, meaning that the primary care provider and the psychiatric consultant all have access to see the care plan. And ideally, the patient does as well. Another requirement is weekly systematic caseload review with a psychiatric consultant. Now, that does not mean that every single patient has to be reviewed every single week, right? That would be unsustainable. But it does mean that every patient has to be available to be reviewed. And I'll talk a little bit more about what that means and how we document it to make sure that we're meeting this billing requirement. But that is a component. Use of registry to track visits and outcomes, that is a requirement. Ongoing collaboration with the PCP and other treating providers. So again, ongoing collaboration with the PCP is a requirement that can be done via a shared EMR, a shared registry, our shared documentation, things like that. Provision of brief evidence-based interventions, outcome monitoring using validated scales. So again, the same measures that we're using to assess, we are continuing to implement those in order to track progress. And that at the end of care, or as we're sort of teetering towards the end of care, that we are engaging in some sort of relapse prevention planning I like to call it a wellness plan, but providing the patient with some sort of depression or anxiety relapse prevention planning. Now, I'll pause here. Yep.
Hi, there are some questions in the chat. Stacy is asking who develops the treatment plan, be it CM or PCP?
Yep, saw that. So the BHCM develops the treatment plan in collaboration sometimes with the psychiatric consultant. So yeah, the BHCM is the one who is having the primary contact with the patient over the course of the month. And they are specifically trained in the behavioral health interventions. So they would be developing that. But again, this treatment plan is not a very extensive, like, it's not what you're thinking of when you think of a traditional treatment plan. It's some sort of a care plan of, this patient is going to engage in collaborative care. We're going to present them with psychiatric review. What are we do? What intervention are we using with the patient, right? Is it behavioral activation or motivational interviewing? That sort of thing. So it's definitely the BHCM and with some input from the psychiatric consultant. And then
Sorry, there's
ahead.
one more question from Marisol. She has asked, where do we find the list of validated measures? You are mentioning specific measures, not just any measure.
Yep, good question. So I will say, I can pull you a list. Typically, it's the PHQ-9 for depression, the GAD-7 for anxiety, and the PCL5. I don't see the PCL5 used all that often. Typically, it's the PHQ or the GAD are the two most common. If the care is being provided to like an OBGYN practice, you may see the Edinburgh Depression Scale being used. That's the perinatal screener. Right. So you asked about, yep. So as I mentioned before, so the PHQ and the GAD are validated for ages 12 and up. So if we're providing care for children 12 and up, we would use the PHQ or the GAD. There are validated tools for under 12 for anxiety. I have seen the Scared used. As of this moment, there's not really a validated scale that I've seen used in collaborative care for pediatric depression under age 12, which is why the AIM Center really does recommend 12 and up for depression or anxiety collaborative care. But if we do have a child with ADHD, I've seen the Vanderbilt used for ages 6 and up. Stacy asks if it requires a patient signature. No. So the consent is verbal only in terms of the actual consent to treat. And then the care plan does not require any patient signature. It's just a care plan that's shared among the care team. Marisol, does that answer your question about the measures? It sounds like you have more of a pediatric population. Okay, perfect. So yes, like I said, so I've seen the Scared used for anxiety for children under 12. the PHQ-A, if you really look at it, it's very, very similar to PHQ-9. If you have an adolescent population and you prefer to use the PHQ-A, that's fine as well. It's the same scale. It's just kind of worded in a younger language. But that being said, I believe it's still only validated ages 12 and up. So we just don't have a good pediatric depression tool right now. And typically, when we're seeing pediatric depression below age 12, we're usually seeing a presentation that would potentially require more monitoring than what we would do in collaborative care. But it's doable. So I'm seeing Caitlin is saying we use the RCADS. I'm not familiar with that one, but I'm definitely going to look into that. So the question is it just an assessment tool or is it a treat to target tool? A lot of the screeners I've seen, they're just screeners. They're not meant to be administered repeatedly over time. And so then we're not able to use them as a treat to target, meaning we're giving the same tool every 2 to 3 to 4 weeks and tracking progress using that validated measure. So that would just be the question I would be asking at implementation is looking at that screener or looking at that tool and ensuring that it's validated as a treat to target tool and not only validated as an assessment or a screener. I've seen the pediatric symptom checklist used as well, but again, not really so much treat to target tool. So it's why it's why AIM Center hasn't really made a good statement about pediatrics, because not enough research has been done, I think, to validate the measures under age 12. But I'm going to look into that RCAD. So thanks for sharing that. Okay, so yeah, we'll move on. But in summary, I think to summarize, I've seen ADHD treated in collaborative care, ages 6 and up, and depression and anxiety, ages 12 and up, simply because of the validated tool. So if you find a tool that is validated as a treat to target tool below age 12, you can, I would say, check in with the AIM Center, see what their thoughts are, but it would meet their billing requirements. I would say that. Okay. 99484. We've talked about this one a bit. So the only real difference here is it does not require a psychiatric consultant, and it does not require a behavioral health care manager or a care plan. So it is a care coordination code that cannot be billed at the same month as a collaborative care code. So again, what I've seen practices do is if the patient doesn't meet the time requirement for collaborative care that month, but they do meet it for the BHI, the 99.4, then they use that code that month. Okay, FQHCs and RHCs, now it's your turn. So it's pretty simple. There's 2 codes. One for your BHI, which is your 20 minutes a month of coordination, or you get your psychiatric collaborative care management code. That's it. So one or the other. And your psychiatric collaborative care code, your G0512, has a minimum 70 minutes in the first month it's billed and 60 minutes in the subsequent months that it's billed. So there is no 50% plus 1 on this one, which means you do have to meet the 70 minutes in month 1 or the 60 minutes in the subsequent months in order to bill this code. If you're at 59 minutes, you're not billing a G0512, you'd bill the G0511. So it is a minimum of 60 minutes, and that's not there's no wiggle room there. And you don't have any add-on codes. So what that means is if you spend 5 hours, you're still only billing the one G0512 and getting that one payment. They don't have any add-on codes in the FQHC or the RHC world. So these bottom bullets are kind of like what it would, the G0511 incorporates BHI and chronic care management. So it's kind of like an all-encompassing code there. It's just a general care management code. So whether, like, if you have a patient who's receiving chronic care management in a Medicare world, in an FQHC or RHC, they would get that G0511. So if you're doing both, you're still only going to be able to bill the one code, right? If they're getting chronic care management and they're getting BHI services, you're only able to bill one. So pick which one makes the most sense for that patient, and the minutes. That's really it for the codes there. Again, like I said, it's a minimum. There's no half plus one rule there, and there's no add-on codes. So it's just one code. Um, okay. So requirements, very, very similar to what you saw on the Medicare side. So the requirements for the G0511 are exact the same as the Medicare 99484, and the requirements for the G0512 are the same as the psychiatric collaborative care management. Pretty straightforward there, but any questions on those? Okay. All right. So across the board, billing considerations, right? So whether we're FQHC, whether we're Medicare, whether we're Medicaid, whatever, um, what do we need to remember? So kind of summarizing what we talked about a little bit. Monthly case rate. You're billing once a month. Auto added to most commercial contracts. So for the most part, if you get a new commercial contract, you let them know you're doing collaborative care. You got access to those codes for the most part. Check with your specific commercial plan and your specific contract. Sliding fee scales consider bundling. So if you're in a practice that does sliding scale, then you can consider bundling this with the other care that the patient is receiving. I'm reading here. Yeah, so no differentiation for your FQHC in terms of who is the BHCM. The psychiatric collaborative care code is there's no requirement that it cannot be an RN. That there's nothing there that's that. So the only difference really is what is the code, right? It's not the 99, it's not a CPT, it's not the 99 codes, it's the G codes, and the minutes are different. Everything else pretty much stays the same. Yep, absolutely. So I talked about the last Sunday of the month, right? So there is so there is this weird caveat where if you can't bill for two different services in the same day, right? So what happens if you see, like people ask me this all the time, what happens if I saw the primary care doctor, and then the primary care doctor referred the patient for collaborative care, and the collaborative care clinician reaches out to the patient same day? Great, not a problem at all, right? Because we're not billing that collaborative care until the last day of the month. You might say to me, well, I'm in a practice where we have such a high volume that we see lots of patients, right? And then the patient might be seen on the 31st of the month, and now we're getting this like two codes in the same day situation. So in that scenario, you could pick the last Sunday of the month as your billing date instead. Now for the collaborative care, and that would not be an issue. Referral from the provider must be documented to start the clock. So we talked about that, right? The referral has to originate with the medical provider, and has to be documented that they have referred the patient for collaborative care. They had that conversation with the patient about it. They got that verbal consent. That will start the clock in terms of your minutes. I'll talk about the 99494 limit again as we kind of move forward. Most plans will max you out at 2 add-on codes. And again, they cannot be billed by themselves. So you will get that kicked back if you send a 99494 that's not attached to another code. So just make sure that you have a 99492 or a 99493 in that month, and then you're adding the 99494. So you don't need to wait on the, so I'm reading that comment here. So you don't need to wait on the PCP signature. Let me rephrase. That's within your own practice. I would say the date of service is still going to be the last day of the month of care. So just make sure you put that date of service as the last day of the month of care. I wouldn't put the first of the following month. That's going to throw things off. So if the care was provided in the month of October, then we want to make sure that that date of service is in the month of October, ideally towards the end of, the last day of the month. Average time needed for documentation. So Tina, we'll talk a little bit about documentation as we go on, because that one's interesting, right? So if we're documenting in the registry, like we're tracking within the registry, then it's counted in your collaborative care minutes. Typically, I have seen best practice is concurrent or collaborative documentation, so that you're using very little time outside of the patient-facing time for that documentation time. Hopefully, also, like your time spent in administrative work is not counted towards collaborative care minutes. So the billing, the time that you're spending in billing, right, and kind of tidying up, that is not include. You can't count that time. And that in terms of the average, it's going to be really hard to answer because every practice's billing workflow is so different. I have seen some practices where they get billing done in, 1 minute per patient, right? Because it's just they enter the code and they're done. And I've seen others that it's just a very complicated workflow that they've built in their EHR. So it just really depends on the billing workflow that you have. Okay. I must have really wanted to make sure y'all got this because it's in here multiple times. So we've talked about these G codes already. Okay, so moving on. Okay, so question, half plus one FQHC? No, right? We talked about that. You do need the full allocation of minutes. Um, okay. All services billed. We've talked about this one already too. That all services billed under the two codes require a separately billable initiating visit for new patients or those who haven't been seen within a year before starting these services. So, just make sure that again, you have some sort of initial visit, primary care provider seeing the patient, a nurse practitioner, whoever is that primary care provider, has a visit with the patient to initiate the collaborative care services. And yeah, Verna, hi. I'm glad you're here. Verna is saying, remember, notes are much shorter, right? So we're not writing a psychotherapy note here. We're not right. We talked about this earlier. We're not writing a SOAP note here. It's very, very brief. You're just documenting that the care occurred. We're not going into detail on what was discussed in the conversation. Documentation template. So that's an interesting one, Stacy. Yes and no. Like, yes, we can. I mean, what Verna just copied and pasted in there, that could be your documentation. That could be it. Um, it could be just a few sentences, like takes you 30 seconds at the end of the care to at the end of the contact with the patient. Because remember, right, we're having frequent contact with our patients, right? We're calling them sometimes multiple times a week, utilizing behavioral activation or motivational interviewing, and so that note could be really, 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 really brief, kind of like a phone visit or a phone contact in some EMRs. So similar to what, maybe your RN might document if they called the patient to follow up on the blood pressure, as an example. So yeah, reason for contact, quick assessment of symptoms, intervention, goal, time spent, done. Pretty straightforward. Yeah, you do not need, yes, absolutely, Marisol. You do not need an additional licensed mental health provider to treat the patient. Most patients in collaborative care are being treated by their primary care physician and they have a behavioral health care manager. Whether or not they're the prescribed medications. And if they're prescribed medications as well, the PCP is the prescriber in this scenario. The psychiatric consultant is making recommendations to the PCP, who is then potentially augmenting the care. But no, there is no requirement for an outside provider at all. But again, like we talked about earlier, there could be a scenario where the patient has an outside provider for therapy or psychiatric support. It's possible they can have both billed, but that would be separate of collaborative. Okay. There you go. We just talked about that. So even in an FQHC or an RHC, you could be billing psychotherapy, but those minutes have to be separate. And so you could do it, but it is absolutely not a requirement. And a majority of folks who are in collaborative care, that's the care that they're getting. And that is all the research that's been done on the efficacy of collaborative care is in that scenario where the BHCM is the person providing the care to them. We talked about same day billing, really not an issue because it's a monthly case rate. Medicaid. So I talked here about Texas, but I'm realizing now we have folks from all over the country. So I'm really just going to say, we'll have everyone's states in here. If you're interested, we can go ahead and send you out information about Medicaid in your state. But this is ever evolving landscape in terms of Medicaid and coverage of collaborative care. So just check with your state. Okay, we've kind of gone over codes quite a bit. All right, want to talk briefly about avoiding denials and underpayment. So check your claim form, make sure that the number of units are correct, make sure that your add-on code is reported appropriately with the appropriate number of add-on codes, meaning if you had an additional 60 minutes beyond the first 60, right? Now you have two add-on codes, right? Because each one is for 30 minutes. So make sure that you have both 99494 is there so you don't lose out on that reimbursement. And check your patient's benefits, right? Do they have a copay? Do they have a deductible? Rule of thumb, if they have cost sharing for medical care, primary care services, they probably have cost sharing for collaborative care as well. It's usually pretty similar in terms of what their cost sharing will be. And also kind of just keeping in mind that, again, it's a monthly case rate, so they're only going to pay, at most per code, right? So it's not per contact, it's not per visit, it's not per encounter, it is once a month. And if the patient has multiple coverages, right, like dual insured, just make sure you're following your payer procedures for primary and secondary coverage. Okay, we've talked about the 99494, always payable, except when noted. Many payers don't restrict the number of units, but some do. So check with your payer. And we'll also talk about that, like appealing. I've seen some practices where they only bill the two, right? Because they're like, well, I know that the third and the fourth and the fifth are not going to be covered, so I don't bill them. I've seen others who have billed them, they get denied and they appeal it. And that's, depending upon the clinical presentation, it's possible. And it, again, allows for future advocacy and things like that. Okay. So I'm going to pause there. I've got a lot of FAQs and a case study that we could go over, but I know we had sort of planned for the last 20 to 30 minutes to be Q&A. So wanted to open the floor up to some questions that the group might have. And then if nobody has any questions, then I will ask and answer the questions because I know that there's a lot of questions that I've gotten over the years. Yeah, Verna highlighted the fact that there are several plans that will pay for more than two codes. And some will also deny the whole claim, so just check with the payer. And of course, you can always reach out to Verna or myself for some help there if you do get stuck. Sometimes it's simply providing education to the payer. Okay, thank you, David. Because the person processing the claim just doesn't know, right? We have seen that happen where it gets kicked back because it has the word psychiatric in it and they think it's a behavioral health code and then they don't want to cover it under the primary care. And then your billing person has to call them and be like, no, this is a primary care code. Look at the CMS guidelines and just advocate. And then they reverse it. So just something to keep in mind. Yes, Stacy, I'll make sure the slides get out. With QHC, does Medicaid get the G codes or the 9 codes? That's a good question. So these codes are the FQHC codes. So I would use those G codes. They would use those G codes because they're FQHC or RHC. But yeah, you can always check with your state as well. But that's a good question. Medicaid and FQHC. And like I said, there's some Medicaid, state by state is different. There's some states that have a different code altogether for collaborative care outside of those codes. So just check with your state. Just because we have such a wide range of folks on this call, it's just easier to advise that. But if you let us know what state you're in, we could always check. If it didn't, this, right? If you didn't document it, it didn't happen. So make sure that any minutes that are provided to the patient are documented with a quick 1-liner, 2-liner, 3-liner about what that time was, right? So if it's reached out to patient to provide resource on 478 breathing, right, whatever, something quick that we did just to document and then put the time. We want to make sure that time gets captured. So I have a nice little case study here. I'm not going to go through it. It'll be in the slides. It's also from the AIM Center, but just really to highlight that your care can and should be fluid, right? So in your first month of care, right? This might happen. This is how many minutes of BHCM activity. This one had 150 minutes. So these are the codes that are being billed. But in month 2, maybe it was less. So we're going to build different codes. So just kind of know that this care can be and should be fluid as the patient's needs change. So just know that's here. All right, thank you. So any questions from the group? Like I said, I've got quite a few here. Some we've talked about already. So if you think of something, please interrupt me, come off mute. Care codes in the same month. Yes, we've talked about that. Yes, you can. Just make sure that the minutes are not being double counted. So if the same provider is the BHCM and the psychotherapy provider, make sure that those minutes aren't being double dipped. But I've not seen that often. So just something to keep in mind. We talked about ages already. So again, the measures tend to be validated for ages 12 and up, which is why we say 12 and up, with the exception of the ADHD Vanderbilt, which is 6 and up. But the CoCM billing codes do not specify any age. This one came up recently. Can travel to meet with a patient in the community be counted in the minutes for billing collaborative care? So if, let's say, this practice decided that they're going to provide this care in the community for some reason. The long and short of it is no. AMA specifically excludes travel time as countable time for evaluation and management. Same applies for collaborative care. Travel time is not, it's considered administrative and not clinical time, so it's not countable. Is there a maximum amount that can be billed in collaborative care? So we talked about this. FQHC and RHC can only bill one code. So no add-ons, no exceptions. FQHC, RHC, you can provide as much care as you feel you need to, but you're only getting reimbursed for the one code. For the other payers, most insurances will cover 2 codes. Likely excess codes will be denied, but they can be appealed. But just remember, I think if you start to get into the point where you're spending upwards of more than 2 hours a month per patient, probably not implementing collaborative care with Fidelity. So let's make sure, kind of look at how are we providing the collaborative care, and ensure that it's meeting those, kind of those guidelines. Yeah, Verna said for commercial plans, you can bill more than one code. Are both collaborative care codes, the base and the add-on code billed together at the end of the month? Yes, right? So most payers will not honor the add-on code if it's billed separately. So make sure the best practice, bill all your codes at once, same day of the month. We talked about this. Somebody asked about the nurse in the practice. Only the BHCM's minutes are counted towards monthly billing. So the caveat was this RN is acting as the BHCM. So in that case, then yes, those minutes are, they're the behavioral health care manager in that instance. But for example, if the PCP is calling the patient about a medication, right, that's not collaborative care. That can be billed in some other way, perhaps, but it's not counted towards the collaborative care minutes. This was a question that came up too. Does the site consultant need to be in network with the insurance plan in order to bill? No, it doesn't matter what network the site consultant is in because they are not the ones billing. The billing is not going out under their name. Communication about the patient between the BHCM and the treating provider, does that count? Yes, it does. So time that the BHCM is spending with any other member of the care team communicating about that patient, that time is counted. How does it affect billing if the patient is getting other counseling services outside of collaborative care? We talked about this. So receiving counseling from a therapist outside of CoCM does not have any impact on billing, but cannot be counted towards the billable minutes, right? We've kind of talked about that at length. The time that counts towards billing is that when the BHCM is providing or coordinating care for the patient. So this could include coordinating care with an external counseling service. This could include keeping the external therapist informed or involved in the treatment plan, assuming that the patient has agreed and signed an ROI. That time is countable because it is clinical in nature. So there is a scenario where this patient receiving outside services, some of that, as long as the BHCM is providing that time, that time is billable. Location of the BHCM. CMS does require that the BHCM is available, or that a BHCM, right, is available to see the patient in person if needed. But they're not required to work in the physical location, and they are not required to ever see that patient in person or face to face at any given point in the care in order to meet requirements for collaborative care. So majority of patients who are in a practice where the BHCM is offsite, most of them will never see the patient. The requirement is simply that there is a BHCM available to see the patient should that patient request an in-person visit. And I've also seen some folks do, face-to-face over video as well. Any other questions? I got tons. I mean, I could sit here all day asking myself questions and answering, but I'm sure that you all might have some specific questions. So just want to put that out there again to the group as we continue to go through these. If anything comes up, stop me, put it in the chat, come off mute, whatever feels good. This one again has come. Oh, I promised you guys I'd tell you about how to document that everybody was available for PC. So here it is. So this is where it gets really tricky. And the billing language says that every patient has to be available to be presented to site consultation. It does not mean every patient has to be presented every time, right? Because if you think about it, most BHCMs are with their site consultant 1 hour a week, and they could have a caseload up to 90 patients. There's no possible way they're going to go through 90 patients in an hour, right? So this statement at the bottom should be included in the notes for every patient every month. The patient has been included in the caseload review activities and consulted on as needed. This guidance is coming directly from the AIM Center. I can't take credit for it. I didn't make it up. But this language added to the documentation for all patients each month ensures compliance because there's a shared registry, and the BHCM and the site consultant are utilizing a shared registry to systematically review all the cases and choose the patients who require consultation at that moment, right? So we're looking at all the patients, we're looking at their validated measurement tool, right? Their treat to target numbers. We're looking at who's not improving. We're checking off the box if, highlighting a patient who's having a side effect so that we make sure to present that patient. Anybody with risk, right, is being presented. So we're using this shared registry. So all patients are included in the caseload review activities. And that's how we go ahead and meet that requirement. Yeah, Verna put in the chat, let us know how we can continue to support you. Our, support doesn't end when this call ends. My email address will be at the end of the slide presentation. You're welcome to email me directly if you think of anything after the fact. Definitely let us know, and we're happy to support. And again, so this question, right? We talked about the BHI code versus the collaborative care code. You can only pick one in a given month. So pick the one that makes the most sense based on the minutes. So if you met requirements for minutes and care for CoCM, let's go ahead and let's use that one, right? Because you're going to reimburse at a higher rate. Your BHI code, we're going to use that one when we didn't meet the requirements for collaborative care. Just pick one. And then if the next month it has to be a different code because of time, that's fine. It can be fluid. So again, just because the patient didn't have psychiatric consultation that month doesn't mean they can't get a collaborative care code that month. It just means that the site consultant had to be available, which they were. So it's really going to just come down to minutes and BHCM involvement. So as long as the BHCM is providing the care and you get the minutes, collaborative care code. If for some reason you lose your BHCM and you don't have anybody acting as a BHCM, and you're still doing some care coordination, then you could do your BHI code then. Or you have your BHCM and you just didn't meet minutes for whatever reason, but you did meet minutes for the BHI, then you do the BHI. And keep going here. I'm gonna feel free to, if you guys stop me, if you guys think of anything. Thank you, Maria. That's helpful to hear. I know it can feel really redundant, the billing stuff. but it's honestly, it's like constantly getting clarified, right? The stuff that was ambiguous is getting cleared up. And so it's always good to kind of like get a refresher. And sometimes, it's just you hear some, there's so much to go over this. Sometimes I know it can kind of get lost. So the out-of-pocket cost for patients billing using collaborative care codes, um, it varies obviously, right? It's going to vary based on the payer. So kind of general rules of thumb. My general rule of thumb is I'll ask, what do you normally pay when you see your doctor for a sick visit, right? Because not a preventative care, because that's usually a different bucket. But what do you usually pay if you have the flu and you got to go see the doctor? That's pretty similar to what you're going to pay for collaborative care, right? So Medicare, they're going to have a 20% cost share unless they have a secondary insurance. And you know what your Medicare reimbursement rates are. So you could actually give that patient a number, right? Your Medicare Advantage plans and your commercial plans, it's going to vary based on the coverage, right? I think, you take one look at the ACA marketplace and your eyes are going to go cross-eyed looking at all the different plans and the different coverages. So it's very independent. It's plan specific. You can't even say, oh, well, they have Blue Cross Blue Shield of California. It's 1,000 different plans. So I encourage the patient to contact their insurance provider. You can give them the CPT code that you're going, you can give them the 99492 and say, find out what this coverage is, in your specific plan. If it's really that important to them, if they make a fuss about it. If they have a high deductible health plan, usually they're going to pay full cost for services until they meet their annual deductible. There are some exceptions where collaborative care is considered preventative and then is exempt from the annual deductible. So again, just encouraging the patient to reach out to their plan specifically. If you're FQHC or RHC, you're going to have a predictable cost share, right? Because you're going to know what that is based on the revenue of that practice. But this is why consent is required and includes informing the patient that cost sharing may be required. And your informed consent can be as simple as explaining to the patient there may be some cost associated with this care, congruent to what you pay for other primary care services. And if you've stated that and you document, verbal consent received for patient informed that cost sharing may be required, that covers you. But of course, we want the patient to feel good about the care that they're receiving. And so if it's a prohibitive factor for them, then you'd want, you can encourage them to reach out to their this one, I know we talked about it before, but I brought it up here again because it is a frequently asked question, which is what is and isn't considered billable time. And the clarification of this is constantly being iterated on. But as of September of this year, this is the most accurate. So time the BHCM is spending on any clinical care with the patient or on behalf of the patient or with other members of the care team or with outside providers, that is billable. Now, if your BHCM is like, well, my patient has, needs this service and I don't know anything about it and I have to spend 2 hours researching it, that's not billable, right? But if they're calling the provider and they're saying, hey, on behalf of patient X, I'm trying to set up an appointment for them and it's specific to their diagnosis for collaborative care, and you're coordinating care on their behalf, then that is billable time. So it's very nuanced. Time doing outreach to the patient. So I'm calling the patient, I'm sending them an email or a portal message. That's billable time. Time spent documenting in the registry specifically to track the patient's engagement is billable time. Time spent, just documenting. If I'm writing a really long note, even though I shouldn't be because that's outside of the scope of collaborative care, that time's not countable. So just make sure that we're in the EHR or the registry and we're tracking the patient's engagement in progress. Then that counts, but we don't want to double dip, right? So if we have a separate registry, and we're tracking in that registry and then we're taking that same tracking and we're putting it in the EHR, we can't count it twice, right? So just keeping that in mind. What is not counted is clerical or administrative tasks. So scheduling an appointment. appointment reminders, transcribing an encounter. So documenting a note, that is not counted. Now, if I'm updating the registry, I'm putting a check mark that says the patient needs to be seen by the site consultant, or I'm putting in their PHQ-9 score. The registry management is billable. The actual transcribing, if that's your practice, is not. And then time spent by the billing provider or the PC without the BHCM involvement is not counted. So just kind of keeping that in mind, right? The site consultant is sending a message to the PCP and the PCP is sending a message back. Unfortunately, without the BHCM involved, CMS tells us that that's not counted. Okay, there's a question came up about the BHAI codes. This is the assessment, behavioral health assessment and intervention codes that are done usually in primary care. These are not counted towards collaborative care minutes, but you can bill them separately if that's your clinic's practice. So just make sure that the ICD-10 code is not the same as the code you're using for the collaborative care. Because when they come into collaborative care, they already have to have a BH diagnosis. So the idea is that this BHAI has already happened. So that time, again, we're not going to double dip time. And we talked about this a little bit, right? It says that we want the master's or license in the area of clinical care, or that they have specialized behavioral health training. And that guidance is vague, and it is vague intentionally. It is open-ended because there's many ways that an RN or bachelor's level individual could acquire specialized training in collaborative care, in motivational interviewing, in behavioral activation, in treat to target, in brief intervention, things like that. So if they have all that, then they could qualify for serving in a BHCM role. So there's nothing that says that the person has to have certain training. It just says they have to have specialized behavioral health training. All right, folks, that's all I have for you. Any questions from the group or whomever is left? Okay. Well, I'm happy to stay on as long as y'all need. If anybody has anything they think of in the next few minutes, or want to kind of bring up one-on-one, my contact information is here. Welcome to reach out to me directly. Let us know how we can continue to support you. Awesome, Robert. Thank you so much for that. Want to just remind everybody too that the case study is in there. It is in these slides. I didn't think it made sense to go through it. But if somebody really feels like they want to hear it or see it, I can go through and explain it to you. The AIM Center provides us this case study just to sort of highlight that these codes can be very fluid month to month, depending upon the care the patient is receiving. And so, I would encourage you to review that if it's still maybe unclear, or stay on and go over it if folks really want to hear about it. Long story short, right? Always bill your E&M codes as appropriate for your PCP visits. That's not going to change, which is a good thing, right? Because we want to still be able to capture that revenue. So those E&M codes, right? For any time the patient is seeing the PCP, we're still billing those E&M codes. Now, if the BHCM is seeing the patient, even if it's the same day, so here's a really great example, right? September 5th, patient saw the PCP. PCP refers them to collaborative care. The BHCM is in the practice and sees the patient for a warm handoff. Great. Sees them same day. That's 15-minute visit is tracked. And then 5 minutes to enter the patient into the registry. That's tracked. So now we've got 20 minutes, right? Same day of service. It's fine. Doesn't matter. Patient get in BHCM sees the patient again later on in the week. Sees the site consultant. All this time, you can kind of see the pattern here, right? All that time gets tracked. And at the, care coordination is happening, right? So here we have September 17th, BHCM organizes a discussion with the PCP to review the recommendations and discuss the problem-solving treatment initiation. BHCM asks the PCP to follow up with the patient on the progress of their visit in the upcoming week. That care coordination conversation, that 5-minute conversation gets billed towards the minutes. If you're messaging the PCP in the EHR or in the portal, the time that it takes you to send the message and review the message that comes back, also billable time. So just kind of keeping that in mind. So anyways, yeah, you get the point. The case studies here, please review it. I think it's really helpful to understand a real life example of how, we bill this time. But it looks like most people have to hop. Like I said, I'll stick around. But that concludes our presentation for today. And feel free to reach out to me directly. My contact information is right here on the screen.
Thank you, Tej. I'll
Yeah.
pass it over to Victoria so she can close us out.
So thank you everyone for joining us today. As a reminder to receive the certificate of attendance, which can count towards your CEUs for today, you just have to fill out an evaluation survey. And so I'll be sending out a follow-up email after this, including the link of the recording, the slides, and then the link to the evaluation survey. So just keep an eye out for that. But thank you so much for staying. Y'all have a great rest of your day. Thank you.
Take care, everyone.
Bye. Thank you.